So I wanted to go through, and the purpose of this talk is to go through, the cardiovascular manifestations of Myhre syndrome as we've seen so far. These are the ones that we're quite sure of. I think over time there will be others that we describe, some that may even be predictable, but we haven't seen enough evidence yet in the patient population to be confident about. So let's dive in. Just a sec. Oh, there we go. So disclosures for me, I'm a member of the Myhre Syndrome Foundation Board. I'm also a member of the Marfan Professional Advisory Board, which I didn't put on here. From a more conflict side, I'm a member of the Broad-Beyer Cardiovascular Disease Initiative at the Broad Institute, where we look for therapeutics for different cardiovascular diseases. None of which are touching on Myhre at the moment. So again, the purpose, what I'd like to talk about and go through today is the effects that we've seen on the cardiovascular system so far. I tend to categorize things in heart disease and things that are what we think of as congenital, meaning born with, basically is the easiest way to think about it. And then ones that are acquired, or things that we see develop over time, not necessarily there at birth. These are kind of artificial distinctions in a genetic disorder, but it still helps our thinking about them. So I want to take a step back and also talk about the SMAD4 protein. I'm also a molecular biologist, so when I have patients, I think a lot about what a genetic disorder is and what it's doing within the cardiovascular system. So I'm going to add a little to what Dr. Starr talked about. We know in Myhre syndrome, the SMAD4 protein is affected by changes in the gene, and we know that this occurs in two amino acid positions: the arginine at 496 and the isoleucine at position 500 within the protein. And we know that SMAD4 is a member of a signaling cascade. It's interesting when we have new genetic disorders, and Myhre isn't that new, but I think the awareness is newer. Sometimes we find them in a protein that we don't know a lot about. There's not a lot of work on it. That's not the case with SMAD4. We know a lot about SMAD4 and other SMAD members. And we know that SMADs are a group of proteins that are involved in this, what's called TGF-beta signaling, or transforming growth factor beta signaling. I'm going to take you through sort of the classical description of this, just so you have some understanding of that. And what is TGF-beta? It's basically a hormone. So it floats at the extracellular space, and it binds to a cell to get a certain reaction out of the cell. So TGF-beta, the ligand binds to this receptor complex, the TGF-BR1 and 2 receptor complex, and that activates the receptor. The receptor then, in turn, phosphorylates or adds a phosphate group to SMAD proteins, and mostly SMAD protein 2 or SMAD protein 3 in the case of classical TGF-beta signaling. These are called receptor SMADs. And after those are phosphorylated, they're now active, and they look for SMAD4, the SMAD4 molecule. And so when they're activated, they bind to SMAD4. And SMAD4 has been classically described as what's called a co-SMAD. And that binding allows the proteins to access the nucleus of the cell and make changes in gene expression inside the cell. And that's the purpose of these cascades, is to change the cellular behavior by changing the expression of different genes within the nucleus. But TGF-beta signaling in itself is actually part of a larger superfamily of receptor molecules that behave similarly to TGF-beta but have different functions. And so classical TGF-beta signaling is the one shown here in the middle, but there are other families of TGF-beta signaling, like bone morphogenic proteins or noggin, Activin signaling is a subtype of TGF-beta signaling. And the reason I'm telling you about these other types is that SMAD4 is also involved in these types of signaling. And therefore, a defect or a change in the SMAD4 gene may be predictably cause changes in all of these receptor systems. Excuse me. And I've shown here over on the right some of the cardiovascular manifestations of changes of these receptor systems. We know that TGF-beta signaling, for instance, is involved, in fibrosis after a heart attack and heart failure and aneurysm formation and hypertension. BMP signaling is intimately involved in pulmonary hypertension or increased blood pressure in the lungs. And activin signaling has been recently implicated in heart failure with preserved ejection fraction and even just typical aging processes. So we may expect to see manifestations of all of these receptor systems in patients with Myhre syndrome. I borrowed this slide from Dr. Lin because I thought it really illustrated a good point about why Myhre syndrome is a little different in that it's a gain of function. Just to elaborate on what Dr. Starr was saying about gain of function, it's difficult to read something in the lay press that accurately describes what gain of function is, because gain of function and loss of function can operate both at a gene level and then also at a protein level, and they can be separate and opposite. So I wouldn't key too much on the word gain of function if you read it about COVID or something else, because it may mean something very similar, or it may mean something very dissimilar. But in the context of Myhre syndrome, the reason we think of it as a gain of function is that it's changing the role of the protein to an active state, whereas in HHT or juvenile polyposis syndrome, that gene change is turning off the gene. So now that you have a little bit of background in that TGF-beta signaling, I'm going to take you through the manifestations of the heart disease that we've seen. And I'm going to start on the side of congenital heart disease. The congenital heart disease is quite a broad topic. The forms that we've seen in Myhre syndrome involve coarctation of the aorta, and I'll take you through what that means, tetralogy of Fallot, and then also smaller defects like atrial septal defects, ventricular septal defects, and then something called a patent ductus arteriosus, which is a fetal connection between the aorta and the pulmonary artery that is supposed to close after birth but can sometimes stay open. We've seen congenital heart disease manifestations in about 30% of patients that we've seen at MGH with some form of congenital heart disease. Most of these, if you are a patient or a family member, you probably already know about these because most of them are identified right after birth, and you may have already lived through sort of the treatment of these conditions. Coarctation of the aorta is literally a restriction or a stenosis of the artery, the aorta being the largest artery in the body that comes out of the top of the heart. We've seen about 8% of Myhre syndromes have an aortic coarctation. And the repair of these actually depends on the way it's shaped and its location. But discrete coarctations can be repaired surgically with an open heart surgery. In general, ones that are quite long in the body cannot be easily repaired, and so sometimes are either tolerated or bypassed, depending on the specifics of that individual patient. This is from a study by Dr. Lin of a patient with Myhre syndrome who had an acute coarctation that was identified after birth, had to have surgical repair, and then came back into the hospital at a couple years of life with recoarctation. And recoarctation occurs actually in not just in Myhre syndrome, but in a lot of patients with coarctation. But this can be treated with ballooning of the coarcted area. So the next condition I wanted to touch on is tetralogy of Fallot. This is one of the more common complex forms of congenital heart lesions, We've encountered one patient with Myhre syndrome at MGH, but we've learned of at least 6 additional patients worldwide. The classical description of tetralogy is this tetrad of subpulmonary stenosis or blockage of the outflow of the right ventricle, a ventricular septal defect or a hole between the two ventricles, an overriding aorta, and some degree of right ventricular hypertrophy. This is a spectrum disorder and can be mild or can be much more severe, depending on the formation of the pulmonary arteries. The repair of this condition is surgical and involves both opening up the outflow of the pulmonary artery and then closure of the ventricular septal defect. And depending on how well formed the pulmonary arteries are, can be very serious after the repair, or can be basically almost normal function of the heart. So those are some of the congenital formations that we see in Myhre syndrome. The next thing that we see on a congenital basis is also an arterial hypoplasia, and also an accompanying stiffness of the arteries. This is separate from a discrete coarctation in that this hypoplasia seems to be quite widespread throughout the cardiovascular system. And I think this is in contrast with other mutations that involve SMAD loss of function mutations. I take care for a living of patients with rare arterial disorders, and I have patients who have loss of function mutations in SMAD2 or SMAD3. And in those conditions, we actually see aneurysms or enlargements of arteries, and sometimes what's called tortuosity or twistiness of the arteries. And really in Myhre syndrome, consistent with the gain of function mutation, we see kind of the opposite. We see rectification of the arteries or straightening, and long segments of arterial hypoplasia, or that the arteries are smaller than you would expect for the body size. At MGH, 2/3 or so of patients have had some degree of arch or descending aortic hypoplasia. This is an example from 2 different patients with Myhre syndrome, in which the descending aorta is hypoplastic or smaller really than it should be, and similarly with this individual. And you can see the striking difference between the ascending aorta and the descending aortic size in this case. We've also seen hypoplasia in other arterial territories, including the carotid arteries, as shown in this CTA, but also the renal arteries, and then, as I mentioned, the lower part of the aorta. This is a small carotid artery, the artery that supplies the anterior part of the head and brain, although there was compensatory increase in the arteries that supplied the rear of the head to compensate for this. So next, wanted to shift gears to talk about acquired cardiovascular disease, or things that we see perhaps not right away in the condition, but develop over time. And the first is something that we're just starting to describe better, but what we call a restrictive cardiomyopathy. So I'm trying to explain what restrictive cardiomyopathy is. At its very simplest level, it's a stiffness of the muscle. Basically, the muscle, the myocardium that needs to contract to push the blood out of the heart, is stiffer than it should be. And therefore, it causes the pressure that needs to fill the ventricle to be higher. And so you get back pressure in both the body, the systemic veins, and then the pulmonary veins that come from the lungs. We can see when this happens as swelling of the body or fluid in the lungs. And there's also impairment to blood flow because of this. We know that myocardial dysfunction and restrictive cardiomyopathy, we know about it before Myhre syndrome, is caused by increased fibrosis between the cardiomyocytes, as shown in this picture. Normal myocardial picture is almost all cardiomyocytes and very little connective tissue in most of the heart. But this is an experiment, so this is not from a human, but this is a model of how cardiac fibrosis happens. And in this model, there's an accumulation of collagen fibers outside the cells of the heart. And this is what causes the heart to not relax as easily and be restrictive. We know actually from a lot of work in the field that this is caused by activation of fibroblasts, or the cells that live between the cardiomyocytes. And we know that that is a TGF-beta dependent process. So it makes some sense with what we know about the physiology of SMAD4 and the mutation in SMAD4 protein that causes an activation of this pathway. The next acquired manifestation that we see is what's called a formation of a pericardial effusion. Let me explain what that is. A pericardial effusion is basically a buildup of fluid in the pericardial sac, or accumulation of fluid that can happen either chronically or quickly. Usually there's very little fluid in that pericardial space, and that space allows the heart to move around and not impinge on anything else in the chest. But when fluid builds up within the heart, it can cause the heart not to be able to fill as well, as shown in these individuals with pericardial effusions. We've seen this happen in a not unsubstantial number of patients with Myhre syndrome. This is also from Dr. Lind's paper from a child who had spontaneous formation of these pericardial effusions. We don't know what the inciting event for these in the general population. We often think they may be related to a viral infection, but we can't put our finger on what's triggering these in Myhre syndrome. Standard treatment regimens seem to be effective. That's anti-inflammatory agents, or in some cases, what's called aspiration or removal of the fluid. And the final form of acquired cardiovascular disease that I wanted to touch on is high blood pressure, something that's related to the function of the arterial system rather than to the heart itself. I think all of us are familiar with high blood pressure. You've heard about high blood pressure. In adults, we define it by 140/90, being greater than that level, and we want all adults to be lower than 120/80. In pediatrics, we have to use a sliding scale, obviously, because kids are all different sizes, and so your abnormal values are based on your age and your height and your sex. But the reason we treat high blood pressure is because we know that there are effects on target organs, and that is the three most important that are affected when people have high blood pressure: the kidneys, the heart, and the brain. And we treat high blood pressure in order to decrease the stress on those organs and future insults. Interestingly, again, as I mentioned, for restrictive cardiomyopathy, we know that the arterial remodeling that causes and occurs in hypertension is TGF-beta dependent. That same sort of pathway that causes remodeling of the arteries and causes them to be stiffer than they should be, and in some cases have extra amounts of collagen. And again, that's quite consistent with the gain of function for SMAD4 protein. So how do we use these manifestations that we've seen? How do we use it to direct clinical care right now in 2021? So these are just some very basic recommendations. All of these types of recommendations need to be modified for the individual patient, but In our center, on an initial visit, we want to both image the arterial system and then get a baseline ultrasound of the heart for cardiac function and structure. So generally a CTA or an MRA, depending on the patient's tolerance of laying in a magnet for a long time. And then after that initial visit, right now we're recommending, yearly follow-up with either a pediatric cardiology or adult cardiology practitioner. Well, what about management of these specific conditions? One thing is one reason to have follow-up is so that your cardiologist can look for and ask you about symptoms that may signal underlying disease. So, for instance, restrictive cardiomyopathy is oftentimes manifest by progressive, what's called dyspnea or shortness of breath. Can also cause swelling of the extremities, swelling in the belly, or fluid in the belly, or fluid in the lungs. And if any of these symptoms, occur in somebody with Myhre syndrome, we would need to treat that as a likely restrictive cardiomyopathy. And oftentimes the diagnosis requires what's called a cardiac catheterization, where a tube is inserted into the venous system, and we can actually check the pressures inside the heart to see if this high pressure phenomenon is occurring. In terms of medical management, if we secure that diagnosis, right now I think we should be using guideline-directed medical therapy, because that's what we use for patients with restrictive cardiomyopathy, and that involves 4 classes of medication: beta blockers, angiotensin receptor blockers, something called mineralocorticoid receptor antagonists, and loop diuretics. These are familiar to any heart failure specialist. In restrictive cardiomyopathy, sometimes the dosing is a little harder and we have to accept lower doses. But I think aggressive medical management is really the cornerstone, and having a heart failure specialist if this occurs. The risk, another treatment for this disease when it becomes severe is transplant. We don't fully understand the risks of transplant in Myhre syndrome, although we think it's probably higher than in other conditions. So this is also something that needs to be assessed individually for a patient. And then what about high blood pressure? Well, I definitely think we need to be treating patients with hypertension, even children. It's not going to go away with intervention. It's a part. I mean, the usual things that we tell people: eat less salt and lose weight. That's true, but this is going to be an integral part of the syndrome, and I think people need to be on medical management if they definitively have hypertension. So the choice of the agent isn't entirely clear. I think we need more evidence to direct our choices, but at least right now, angiotensin receptor blockers or beta blockers in childhood seem reasonable to me. And we also need, and should have been done if you had the CTA at initial, is to rule out renal artery stenosis as an etiology, because in those people, we may need to use caution with angiotensin receptor antagonism and check labs or use lower doses. And then one thing I talk to patients a lot about is most of these manifestations are going to come on slowly. And so they're not, general emergencies. That's not true though for pericarditis. Pericarditis can be an emergency. It can come on very quickly and can impair the function of the heart. So one thing to make your life easier is to know where your emergency systems are available where you live. Do you, what if you have a child, what's the pediatric emergency room near you? Do they have the capacity to do ultrasound, which is how, we diagnose this without calling in a cardiologist? Can they do it themselves? Sometimes they have to call in a cardiologist, so that just takes a little longer. So identifying a good emergency response if your child becomes ill, is a core component of being able to respond to this. So, that's the manifestations that I wanted to take everyone through. And I think, in conclusion, the manifestations are really quite compatible with a mechanism that involves continuous overactivity of the TGF-beta superfamily signaling system. Based on previous research, the manifestations that I've described are not going to be exhaustive. We know that these pathways are involved in other cardiovascular manifestations, such as atherosclerosis. It wouldn't surprise me if we find over time that adult patients are more prone to atherosclerosis. And so good primary care with checking your cholesterol and following the recommendations of your regular medical preventive services are really important. And then, I think right now, as Dr. Starr mentioned, we all have a lot of ideas, but right now, I think we need to use evidence-based modalities that we know work in other patients until we can generate some more information about Myhre-specific therapeutics. So I wanted to thank the board of directors and our patients and families for allowing me to talk today, and happy to take any questions. Thanks a lot.
Thank you, Dr. Lindsay. We have quite a few questions and we have about 12 minutes, so we will get through as many as we can. Again, thank you everybody for sending your questions. If we do not get to yours, we can either try at another session or think about a way to get them after the fact. So first question, what are the effects of multiple heart surgeries on patients with Myhre?
So, there are effects of multiple heart surgeries on all patients. Many patients with congenital heart disease, by definition, need to undergo multiple procedures. And I don't think we have specific information about how that is different in Myhre syndrome. I think Dr. Starr and the folks in Nebraska had some early experience with some severe forms of congenital heart disease, but we've also met patients who have had multiple procedures and have done fine. So I think there are concerns with multiple procedures, but that being the case, if congenital heart disease needs to be treated, it's life-threatening, and we can't get away from those treatments.
Okay, great, thank you. Next question, do we know if hypertension develops over time in Myhre patients?
I think we think so. We've met adults and children, and I think the younger individuals are less likely to have high blood pressure, which would imply that it can develop. And then also from what we understand about the pathophysiology of hypertension or high blood pressure, it makes sense that it develops over time in Myhre syndrome. And that's how it works in everybody else in the world too. Hypertension is something that develops in almost all of us as we age. And so it just seems to be occurring on a more rapid time schedule in Myhre syndrome.
Okay, thank you. Can you comment on the likelihood of a recorch? I don't know if I'm saying that correctly.
Oh, probably a recoarctation.
Yes.
Not specifically for Myhre syndrome. I think recoarctation is common in people who have had a coarctation repair early in life. Somewhere around a fourth of patients with coarctation will have a recoarctation and need a procedure to open up that artery. I don't know whether that's more common in Myhre syndrome. We just don't have enough data. But that's why you visit your pediatric cardiologist every year, whether you know it or not. That's what they're looking for. They're looking for evidence of recoarctation and checking for it.
Okay, great. Thank you, Dr. Lindsay. What should we look for in adults with Myhre syndrome and the heart in general in terms of maintaining heart health, general heart health?
Yeah. I mean, I think the general recommendations of the American Heart Association and other cardiology societies are exactly what we should be following for Myhre syndrome patients. Um, that involves checking laboratory studies to see what the status of your cholesterol levels are, controlling high blood pressure if it exists, diet and regular exercise. The things that your doctor talks to you about are absolutely important in Myhre syndrome. I think if adult patients are starting, to see their an adult cardiologist, they, an assessment of their cardiovascular risk around atherosclerosis and those forms of heart disease is really important but that's what cardiologists do in general at your visit. And so, I think that's what an adult visit should center around, in addition to the things I've described.
Okay. Great. Thank you. Is there a med to control CF?
Um, see, is that?
Yeah, I don't know what the CF is. Again, I'm just reading from a list. If someone does know, can you please respond to the comment section? And we'll try to get that question answered. We'll move on to the next question. What tests can be done to see if there is more fibrosis on the heart muscles? Is there a test?
Yeah, that's actually a great question. There are, MRI technology can be used to identify fibrosis in the myocardium. In general, that is not something that we have seen, although we haven't been doing that scan in individuals. I think if that is not something I would recommend doing in individuals until we have more information, unless there was a clinical scenario that suggested that we should be looking for it. I don't think we should be going on a fishing expedition for that unless there's some manifestation that we're worried about, meaning a cardiomyopathy or some other impairment in the heart function.
Okay.
It looks like that's been clarified in the chat. The CF. Oh.
Chronic fibrosis. Thank you.
Yeah, so, is there a med to control fibrosis? There are. In fact, we know that angiotensin receptor blockers, ACE inhibitors, and other mineralocorticoid receptor antagonists, the ones that I mentioned for guideline-directed medical therapy and heart failure, control fibrosis. That's part of their function. There are other anti-fibrotic treatments that are being developed, both in clinical trials, and a couple that have, reached clinical, at least approval in small populations. Those are things that we're thinking about in this population, and that may be of future use. But they do exist, and there are lots of research programs and pharma programs targeted towards anti-fibrotics, because we know it's a big component of lots of diseases.
Makes sense.
Not just Myhre syndrome.
So given the Myhre population is smaller in stature, does that give reason to stay with a pediatric cardiologist for a longer duration, or do you recommend going to adult at some point?
I think it's a good question. So not necessarily from short stature. I think some cardiologists, congenital cardiologists, are comfortable watching, taking care of patients into their 20s or so, especially if they have, congenital heart disease as a child. There are practitioners called that practice what's called adult congenital heart disease. They are probably ideal for an adult Myhre patient, as the condition is a combination of congenital and acquired factors. And so I would think of a patient with Myhre as somebody who would probably benefit from an adult congenital heart disease practitioner. Those kind of practitioners are not available in all areas, and so a good general cardiologist is better than just nothing. And it's hard. The individual practitioner's experience probably is the defining factor, and their curiosity about rare disease. So that may require some shopping around, for want of a better term, and really finding somebody who's wants to engage with this condition.
Okay, great, thank you. Um, is there any evidence for the role of statins for improving the health of the arteries in patients with Myhre syndrome?
I would say there's no evidence. However, statins have been shown to be beneficial in almost every scenario they have ever been tested in. And therefore, if I would consider Myhre syndrome a risk factor for cardiovascular disease, and would use the general calculations, meaning if you have an LDL level that is in the mild region, but you have a risk factor for cardiovascular disease, you may want to undergo statin therapy. Statins are generally tolerable in the human population and have shown unequivocal benefits in people. So if there's an indication for it, I certainly would take it.
Okay, that's great. Dr. Lindsay, we got through quite a bit of questions, so thank you very much for your willingness to answer those and for your expertise.